the two major medications that have been investigated are in current clinical practice for the prevention and treatment of tumor lysis syndrome are allopurinol and rasburicase. Now, allopurinol, what it is a xanthine oxidase inhibitor. And so that's where, as going back to the pathophysiology, xanthine gets converted to uric acid. And so it blocks that. It blocks that enzyme, and therefore xanthine can't be converted into uric acid. So allopurinol is really more of a preventive measure because once uric acid forms, allopurinol is not, it can't help. Or it can minimally help because it can block further uric acid formation, but it's not going to take care of the uric acid that's already there. And it takes a while for allopurinol to completely block that mechanism. It can take up to 24 hours. So you really need to be starting it early as compared to late in the process. As compared to rasburicase, which is a uric oxidase, it's an actually enzyme itself. It actually dissolves present uric acid. So if uric acid's already starting to accumulate, it can take care of that. And if you have high uric acid levels, it can clear those out. Matter of fact, the mechanism of action, it's very, very quick, that within like 4 hours, like if you take a sample, a blood serum sample of and look for uric acid and then measure it 4 hours later, you can see in the majority of patients a dramatic drop in uric acid from the use of rasburicase.
There are different drugs used for managing or preventing hyperuricemia. Allopurinol has been the standard of care now for several decades. The mechanism of action is a xanthine oxidase inhibitor, which is the how the drug works, and it prevents essentially alternate pathways of uric acid production from happening in tumor growth or tumor destruction. The dosing of allopurinol is based on kidney dysfunction, and so the standard dose for somebody with generally good renal function is 300 milligrams daily. If there is some level of renal dysfunction, you can follow the package insert, but then patients are generally decreased to 100 milligrams per day. It's oral and can be prescribed through an outpatient pharmacy. In terms of safety, it's generally well tolerated, but there can be rare complications, rash, fever, liver dysfunction, and there have been case reports of something called the allopurinol hypersensitivity syndrome, which has rarely led to life-threatening complications. In terms of efficacy, it works well, but it's much better at preventing a hyperuricemic event than it is for treating one. The reason is that's not treating acute spikes in uric acid, but it's preventing uric acid buildup in the body. And so it generally needs to be started at least 72 hours prior to the cancer-directed therapy. The alternative drug that we would consider using for either prevention or treatment of hyperuricemia is uric oxidase or rasburicase. And this is an enzyme, so it's different than an enzyme inhibitor. This is actually an enzyme that's used into the body, so it's intravenous. It's generally well tolerated, and what it does is that it actually metabolizes or breaks down allopurinol into more water-soluble versions of itself called allantoins, which are easily water-soluble and can be excreted from the kidney. It's interesting that uric oxidase is an enzyme that every other mammal has except for humans. And so we're essentially giving to people what every other mammal would have. There are only rare theoretical concerns with uric oxidase or rasburicase. One of them is that it can trigger anemic events if a patient has a genetic disorder called G6PD deficiency. There is a concern rarely for second use of the drug in terms of the development of antibodies to this enzyme because it's a biological agent. But outside of those two concerns, I haven't really seen any consequences to its use, and I've never really experienced a side effect. One thing to know about using that drug is because it is an enzyme, and in a sense it's chewing up uric acid constantly, that after you give the drug, you have to be able to store the blood on ice. Otherwise, the drug will continue to work in the test tube at lowering the uric acid, and then you'll have a falsely low level. The big difference between allopurinol and rasburicase or uric oxidase is that uric oxidase can be used for treating acute spikes in hyperuricemia or uric acid and is effective at lowering the level from any elevation down to one that's normal or below normal on the scale of a few hours. It's dosed, I think technically weight-based per the FDA label, but many people use flat dosing, either 3 or 6 milligrams as a flat dose as an off-label use, which works quite well and can last for several days at keeping the uric acid in check.
In terms of prevention, that's where the selection of allopurinol versus rasburicase comes into play, because in the latter situation, when you already have full-blown laboratory and clinical tumor lysis syndrome with high uric acid levels, you're going to be wanting to think about using rasburicase in those situations. In the preventive situation, it really becomes down to that risk stratification that we've discussed before. And those patients at what I would like to describe as a low intermediate risk, you can probably feel very comfortable in regard to the use of hydration and allopurinol alone. But in those high-risk patients, and the classic example, this is a patient with Burkitt's lymphoma. That's when I was in training, that was always the classic case of tumor lysis syndrome, but also very high-grade lymphomas and patients with acute leukemias with a high burden, bone marrow burden, high white blood cell count. Those are the patients I'm going to be thinking about that I'm almost, if they were not receiving, is about a 100% probability that they're going to develop some, at least severe laboratory form of tumor lysis syndrome and likely clinical tumor lysis syndrome. So those are the patients I'm going to be leaning more towards using rasburicase as a preventive medication as opposed to allopurinol.
All patients who are at risk of developing TLS should receive allopurinol unless there's an allergy or some other contraindication. The patients with the very aggressive tumors, the elevated uric acid at baseline, those who have a very high risk of developing TLS despite standard measures like fluids and allopurinol might be the best cases for rasburicase as a prophylactic measure. But any tumor where you're monitoring and you develop a high elevated uric acid or kidney dysfunction secondary to that uric acid elevation would be a good candidate for intervention with rasburicase for treating the hyperuricemia.